goodness. Okay, so let's get started then. So what I will do is I will kind of lay out how epidemiology in Canada look like, and then where we are in Canada with respect to our cascade of care, and then what will be needed in terms of treatment targets. And I will use most of the data from BC with a caveat that we don't have national level data for most of the things. Large number of people are living with hepatitis C across the world and in Canada. Morbidity and mortality are increasing. And we know that the direct acting antiviral agents have been game changer, and that prompted World Health Organization to set very ambitious elimination goals. But with right level of scale up, elimination is possible. And with that background, let's look at what is the epidemiology of hepatitis C in Canada. This is a slide from BC. And the way we started to visualize hepatitis C in British Columbia and Canada, we feel that there are a large number of people who are living with hepatitis C and they are diagnosed with prevalent infections that they acquired decades ago, and now they are presenting with end-stage liver disease. And most of these, and they represent most of the infections or chronic infections in Canada. Like in British Columbia, they constitute about 88% of the infection, and the new infections constitute are occurring among younger birth cohorts who are born after 1965. And these are individuals who have very high level of illicit drug use or injection drug use, mental illness, HIV co-infection, and when you look at material and social deprivation, very high level of material and social deprivation and problematic alcohol use. But when you compare that with people who are getting diagnosed with prevalent infection, the illicit drug use, mental illness, HIV co-infection, and material and social deprivation and problematic alcohol use is much lower than among those who are diagnosed with new infection. So what does that suggest? That among people who are getting diagnosed with new infection, they are among more marginalized and vulnerable population. We will need to treat their hepatitis C infection, but we will need to provide additional support services to improve their overall health and survival. So hepatitis C treatment alone won't be effective, but people who are who are in older birth cohorts and have prevalent infection, they will need immediate diagnosis among those who are undiagnosed and treatment to reduce morbidity and mortality among these populations. So this is following on that theme. So this slide represents the hepatitis C positivity between 1992 to 2015 in British Columbia, where we are able to put together all lab testing since 1992. And this positivity rate is by birth cohort, and I've divided it into three different lines. The blue line is for prevalent hepatitis C infections, and the green line is for seroconversion. That means like people who tested negative and then they tested positive following that. So they are converting from negative to positive infection. So when we look at the prevalent line, so you could see that the most of prevalent infections are among birth cohorts 1945 to 65 or 70. And while when we look at the seroconverters, so they are mainly among individuals who were diagnosed or who acquired infection after, or who were born after 1965. That is also an artifact of our testing systems, and even the baby boomer birth cohort, like the way we are diagnosing infection and seeing like higher percentage of positivity in that could also be the artifact of our diagnosis system, because we started diagnosing individuals after 1992, and some of those individuals from older birth cohort may have already died before we were able to diagnose infection among them. But the point I want to highlight, most of our end-stage liver disease, decompensated cirrhosis, and liver cancer are currently being diagnosed among these older birth cohorts, and very few among younger birth cohorts. And this is the slide that compares decompensated cirrhosis, and the similar trend we could see for hepatocellular carcinoma between BC, New South Wales, and Scotland. And this compares the age distribution of people diagnosed with decompensated cirrhosis among hepatitis C positive individuals. Blue part of the bars are individuals um, um, where age of diagnosis was older than 50 years, and the orange part of the bar is below 50 years. And you could see that in BC, with alcohol use disorder and without alcohol use disorder, bluer portion of the bar is much higher or broader than New South Wales and much broader than the Scotland's. And that suggests that most of our hepatocellular carcinoma and decompensated cirrhosis are related to aging of people living with hepatitis C. And then, of course, there is an added effect of alcohol use, because you see there is a difference in distribution between those with and without alcohol use disorder. So this is a very important slide, and we have a poster describing further details about this. So this slide presents causes of death among by hepatitis C status and birth cohort. Individuals who are diagnosed who are negative for hepatitis C, and on the right, individuals who tested positive for hepatitis C. And you could see that in the older birth cohorts, liver-related and the other cause-related mortality, which is represented by green bars and blue bars, it's much higher. In birth cohort 1945 to 64, you still see some drug-related mortality. But the important thing to highlight and note in this slide is, among individuals who are born after 1965, drug-related mortality is much higher than liver-related mortality and other cause-related mortality. And that mortality would not be affected by hepatitis C treatment. So that is the point that I wanted to highlight, that we will need to provide support services for drug-related harms to prevent mortality and improve survival among these individuals. So moving on to global hepatitis strategy. So WHO set up a very ambitious goal for eliminating hepatitis C and hepatitis B by 2030. What are these goals? To reduce a number of deaths related to liver disease by 65% and new infections by 90% by 2030. What are some of the services scale up or the targets that will be needed to achieve that? That is 90% of individuals being diagnosed by 2030 and 80% treatment initiation. Among harm reduction, having more than 300 needles and syringes distributed per person who inject drug. And then for OST targets, having more than 40% of people who inject drugs on OST. Blood safety and injection safety, these are medical injections. We are doing much better in these areas, but the other areas are important to note from our programming perspective. So how we are doing with respect to providing these services or cascade of care. We don't have like the overall cascade for Canada. So this is the cascade that we try to pull together in British Columbia by integrating data on lab testing, mortality, and prescription drugs. And this is the cascade as a baseline to show that there are gaps at all steps, from diagnosis to confirmation of infection to genotyping to treatment initiation during interferon era. But the major gap was at treatment initiation during interferon era, and of course, like SVR were low. When we look at the cascade of care, I won't go into the detail of this. Nuria will be presenting much more details about the cascade of care for 2016 and along other groups, but we see that the improvements across all steps with increasing treatment rates. This was a recent review looking at the global coverage of needle and syringe distribution among people who inject drugs across countries. And you could see that in Canada, our number of people or number of people who inject drugs, number of needles and syringes distributed per PWID are less than optimal compared to WHO targets. And the next slide, and this is the data is from British Columbia. I didn't have access to overall Canadian data to break it down by province. But when we look at within British Columbia, we see that there are areas which are doing quite okay with respect to WHO service coverage targets, but then there are areas, especially in rural area, where coverage is suboptimal and will require considerable scale up. This slide looks at the global coverage of opioid substitution therapy across countries. Darker colors represent greater than 40 OST recipients per 100 PWIDs. And we see that in Canada, our OST coverage is also suboptimal. This is data from British Columbia by health region, comparing data from 2009 and 2016. You could see that there have been improvements in our OST coverage over this time period, but still there are areas where coverage is suboptimal and it needs improvement. So now shifting to some of the modeling and some of the treatment scale up and its impact on overall elimination. So this is the data that comes from model that is developed by Center for Disease Analysis that Homi presented in his talk, and that was used in rest of the world for developing and making some of the policy-related decisions. So this is a system dynamic model developed to quantify burden of disease and disease progression in hepatitis C infected population from 1950 to 2030. So it moves people from acute infection to end-stage liver disease, and it divides people and using various age and sex groups, and uses published transition probabilities or the probability to move from one stage from one stage of liver disease to the next stage. And for a lot of data comes from BC hepatitis testers cohort, but the transition probabilities were derived from literature. Just like the overall, from the conceptual point of view, people move from acute hepatitis C infection to either spontaneous clearance or develop chronic infection, and they go through various stages of chronic liver disease and develop end-stage liver disease, either hepatocellular carcinoma or decompensated cirrhosis or liver transplant, and so on. So what we did, I will present you most of the data from British Columbia, where we did some exercise looking at the various treatment scale-up strategies. So in this, we used our baseline number for 2016 as treatment, where we treated about 2,300 people. In 2015, our number of treatments were much higher than 2016. So we used that as a kind of a status quo. And at that time, we were treating people with F2 and higher, so we left it as F2 and higher for 2017 to 2020, and then in the next strategy we changed this to F0, and then we increased the treatment to 4,000 per year, 5,000 per year, and 6,000 per year. And in the next few slides, I will show you what is the impact of these various levels of treatment scale-ups over the period of time. So this slide shows impact of various treatment scale-up scenarios on liver-related mortality. And you could see, and it represents two graphs. The graph on the left side is trend is mortality over time for various treatment scale-up scenarios. And the graph on the right side is percentage change from 2015 in mortality. And then I have two bars. One is for 2020 targets, and then 2030 targets. And you could see that the overall, we will need between 5,000 to 6,000 people needs to be treated to achieve a greater than 65% reduction in mortality by 2030. And you could see that the current status or the current number of treated treatments, it won't take us anywhere, and we will have to at least go to 4,000 to 5,000 treatments to have a significant dent in the reduction in mortality. So liver cancer is not one of the targets, but we looked at the liver cancers as well, and you could see that a similar kind of trend in terms of overall reduction or change in trend in liver cancers, as well as a percentage change from 2015. We will need to treat about 4,000 to 5,000 individuals in British Columbia to reduce liver cancers by 65% or more than 65%. When we look at total number of chronic infections, same kind of scenario. So at the end of day, with all scenarios, your total number of infections will decline, but how fast they decline And when we will achieve that, that depends on like how many people we are treating and how fast we are scaling it up. So we will need like to treat between 4,000 to 5,000 people to achieve like greater than 90% reduction in total number of infections. And if we treat people between 5,000 and 6,000, then most probably we will achieve elimination earlier than 2030. So so then I kind of like, I will use like next two slide to kind of show very preliminary data on Canada. So this data needs to be updated. We had a modeling workshop, a very productive workshop on Wednesday to kind of discuss some of the input parameters and other things. So this is really work in progress. But just to kind of illustrate some of the concepts here, in the status quo, number of treatments are declining over a period of time. With WHO elimination, we increased treatments to about 20,000 for a few years, and then bringing it back to 9,000, which is the current level of treatments. And then aggressive scale up is treating 25,000 people per year. And you could see that we will need to treat, at least in the WHO elimination scenario, about 20,000 people for next 4 to 5 years, and then we could decline it to 9,000. So it could be, so that way, like we could achieve overall reduction in mortality. And when we look at the total number of chronic infection, the similar kind of scenario. So this work needs to be, we will work on it and update, and we'll present it back in next little while. But this highlights that the current level of treatment levels that we have, that won't achieve WHO elimination targets as we stand. So this needs a significant level of scale up to achieve these elimination targets. So these data needs to be interpreted in the presence of some cautions. The outputs are based on input parameters, and as you know, like the input parameter, it depends on availability of data, especially for overall Canada. Input parameters or the data is really limited. And we had some discussions to kind of refine some of these inputs, and same like for even for British Columbia, some of these are not really robust. So we have to interpret these data in the presence of these uncertainties. This model does not account for transmission. So there is a separate model that accounts for transmission. So from that point of view, it could be underestimating the overall impact of treatment on elimination targets. And then it's also assumed constant incidence rate, like number of new infections, and which may underestimate the number of new infections or overestimate the number of new infections. At the end, to summarize, within Canada, we have like two major types or multiple types of epidemics. One is people being diagnosed with prevalent infections who are no longer engaged in activities that are leading to forward transmission, but they are presenting with end-stage liver disease and require treatment, and those who are undiagnosed require diagnosis and treatment to prevent end-stage liver disease. People who are getting diagnosed with new infection and people who are injecting drugs, they have multiple co-occurring conditions and social vulnerabilities, and they require services related to mental health and addiction treatment and safe drug supplies to prevent mortality and to improve their lives, along with hepatitis C treatment. Hepatitis C treatment alone won't be sufficient to achieve elimination in that population group. So Cascade of Care shows signs of increasing treatment rates, which we don't have like a full handle over the Canadian cascade. And based on some of the data that we know, a substantial level of scale up of treatment and prevention interventions is needed to achieve reduction in hepatitis C infection, mortality, and end-stage liver disease. And at the end, data and surveillance is key to understanding where we are and where we need to go. And we need to invest in gathering data at national level and at provincial level to make informed decisions. Thank you very much for your attention. And I would like to acknowledge work from all collaborators on their behalf. I'm presenting all of this work. I didn't do any of this work that I presented. Thank you very much.